Okay, good afternoon, everybody. We're going to get started now, so we have a jam-packed hour and a half for you. So I just wanted to welcome you all to our webinar today, Dementia Caregiving as a Public Health Priority, How iGeriCare.ca Can Help. My name is Claire Howarth. I'm a research coordinator here at the National Collaborating Center for Methods and Tools, and I will be your moderator for the webinar today. Before we begin, there's just a few small housekeeping items. Please use the chat box to post any comments or questions throughout the webinar, and send questions to all and not just privately to host. If you're having any connection issues, we recommend using a wired internet connection versus the wireless connection, and the WebEx 24/7 helpline is up there as well. If you happen to not be able to see the chat box, it should be in the panel on the right-hand side of your screen. If you hover over the bottom of your screen, you'll see a little kind of speech bubble icon. If you click on that button, it will open the chat box. After today, we'll be posting the slides and audio recording online, and the links are there. We will also make sure to post that on our social media feeds for anybody interested in accessing this information. So we just have a few poll questions to start off today. When the poll opens, you'll notice it pop up on the panel on the right-hand side of your screen. So the first question today is, how many people are watching the session with you? Is it just you, 1 to 3 people, 4 to 5 people, 6 to 10 people, or more than 10? And I'll just give you a little bit of time to answer that. Okay, so it looks like we have most people have answered, so we'll move on to the next poll question. Have you visited the NCCMP website or used its resources before? It's a pretty simple question, yes or no. Okay, great. Thanks for everybody for answering. And we just have one last question. If you answered yes to that previous question, how many times have you used the NCCMP's resources? Once, 2 to 3 times, 4 to 10 times, or 10 or more times? Okay, great. Thank you again for everybody who answered that question. So as I said before, I work for the National Collaborating Center for Methods and Tools. We are one of 6 national collaborating centers across Canada. The National Collaborating Center for Methods and Tools is hosted at McMaster University in Hamilton, Ontario, and our goal is to support public health professionals and organizations to integrate evidence-informed decision-making into our work. The National Collaborating Centers are funded by the Public Health Agency of Canada, and we will each focus on a different priority public health topic. So from the west, we have the National Collaborating Center for Indigenous Health in Prince George, British Columbia, the National Collaborating Center for Environmental Health in Vancouver, British Columbia, the National Collaborating Center for Infectious Disease in Winnipeg, Manitoba, the National Collaborating Center for Healthy Public Policy in Montreal, Quebec, and the National Collaborating Center for Determinants of Health in Antigonish, Nova Scotia. And at the NCCMT, we have many products and services to support public health professionals in engaging in evidence-informed decision-making. This includes the Registry of Methods and Tools with over 270 methods and tools, online learning opportunities, including our 13 online learning modules, workshops, Public Health Plus, which is a repository of public health research, our video series, including our Understanding Research Evidence videos, which go through concepts important to research in short and easy-to-understand videos, and also networking and outreach. If you see us at any conferences, come and say hi. So today's presenters are Dr. Anthony Levinson and Dr. Richard Stramko. Dr. Anthony J. Levinson is an associate professor and the director of the Division of E-Learning Innovation, or DELI, at Michael G. DeGroote School of Medicine at McMaster University, and also the co-founder of iGeriCare, an online dementia education program for caregivers of persons living with dementia. He maintains an active clinical practice in the area of medical psychiatry with a special interest in neuropsychiatric disorders. Dr. Richard Stramko is an assistant professor at McMaster University and practices both geriatrics and general internal medicine. Through his work with people living with dementia and their families, Dr. Stramko came to understand that there is a desire and need for online education about dementia that has been developed by experts in geriatrics. This inspired him to pursue the creation of iGeriCare. So with that, I will pass it over to Dr. Levinson and Dr. Stramko.
Thank you very much, Claire, and it's our pleasure to be here today. And I wanted to start off with a couple of quick scenarios. Today we're going to talk a little bit about dementia caregiving as a public health priority and how our iGeriCare resource can help. But I think it's helpful to illustrate some of the key dilemmas that many people face in clinical practice and public health practice working with caregivers of people with dementia. So take a scenario like this. You have the son who is a caregiver whose father is living with dementia. The son is new to this. He's accompanied the patient to a clinical visit with the family physician or maybe a geriatrician, and he has so many questions. There's so much to understand. The clinician, who is also super busy, would love to spend more time and educate the caregiver about the illness, but it's a busy clinical situation and there may not be time. Imagine the scenario where a home care nurse is helping out maybe an hour a week, 2 hours per week, and they're in the home with the caregiver and the care recipient, and they would like to provide more education, but are also limited in terms of their time. The Alzheimer's Society offers fantastic programs in the community for caregivers, but what about for those caregivers that may not be able to make it to in-person caregiving, or maybe can't attend all of the sessions, or maybe they have other family or friends involved, and those people would also like to participate but can't necessarily join the caregiver sessions put on by the Alzheimer's Society. So those are some of the vignettes and scenarios that help to drive Dr. Stramko and I to create iGeriCare. But I guess part of the goal today is really to do the Jedi mind trick, because I think there are some very important ways in which dementia is a public health issue, but may not be perceived by everybody to be that caregiver health and wellness is a public health issue as well, and how we think iGeriCare may help within that landscape. But that's some of our role today. As Claire said, I'm a psychiatrist, but for about 20 years now, I have been the head of the Division of E-Learning Innovation at McMaster University, and I have a research chair that focuses on really technology-enhanced learning and how to design web-based training and learning for a range of different audiences, including healthcare professionals, trainees, and the general public. And I was fortunate to team up with my colleague, Richard.
Yeah, so I'm Richard Stramko. I'm a practicing geriatrician, as was noted. I have a clinical fellowship in behavioral neurology, so I deal a lot with neurodegenerative conditions, including Alzheimer's, but also some movement disorders. And for about the last 6 years, I've been involved in using technology to improve healthcare outcomes. So I'm the chief medical officer of a company called Relic, and then I've been fortunate enough to team up with Dr. Levinson in this regard in helping create iGeriCare.
So I want to start off with just one or two polling questions to get a feel for how many of you actually have dementia within one of your public health priorities. I know there are some public health units that focus on it, so this polling question, for how many of you is dementia within your set of priorities? Okay. So, and can we just show the results? It looks like about a third of people are setting this as a priority. So let me if I ask you the next question, maybe that will change how you perceive it. So the next question is really, maybe you don't have dementia on your radar, but what about brain health or healthy aging? Is that something that is more a fit with your current mandate? So yeah, it seems like there's maybe over half of you have brain health or healthy aging, but maybe not dementia as a disease entity. So, okay, great. Well, I want to spend just a little bit of time talking about the public health landscape and in particular, the dementia strategy for Canada from the Public Health Agency of Canada. Some of you may be aware of this. This is a relatively new development, and I'm going to not spend too long on this, but I guess I want to make the case for why dementia is an important public health issue and why caregivers, particularly caregivers of people with dementia, is also relevant. So actually these data, even from the time the report came out, are probably underestimates. It's thought that more than 500,000 people are actually Canadians, 500,000 Canadians are living with dementia. That's probably an underestimate because there's some reasonable evidence that a lot of people don't actually get a diagnosis of dementia. And what we do know from some of the statistics is about 83% of those people are dependent on informal family caregivers for a significant amount of their care. But you can see some of the data. Basically, as we have an aging population, there's a number of new cases. I always find it a bit terrifying when you have the, every hour 9 seniors are diagnosed with dementia in Canada. So by the end of this webinar, we'll have increased the number. But the fact is, this is a very important illness, and as the demographic of our national population shifts, it's estimated that the numbers with the disease will double in about 15 years. The number of caregivers will continue to increase. Now, the national strategy sort of focused and hovers around 3 main principles or objectives. One is around preventing dementia. The other is around advances in therapies and finding a cure. And the third one is around improving the quality of life, both of people living with dementia, but importantly, for caregivers as well. And, I'm not going to go into too much detail about it, but I think it's interesting thinking about preventing dementia, which we'll come back to. There's 5 kind of core underlying pillars within the strategy. And when we talk a little bit more about iGeriCare, it really falls into the area thinking about information resources, but there's elements of it as well that might be applicable to developing a skilled workforce as well. And we'll maybe talk about how collaboration fits in too. When we talk about preventing dementia, part of it is about understanding some of the core risk factors for dementia. And there's a few of these that, lower levels of early life education, hearing loss, depression, but physical activity. But a lot of these might also be familiar to you because of other chronic diseases, things like obesity, physical inactivity, diabetes, social isolation. So I think these are the risk factors for dementia are probably also aligned with some of the other public health programs around healthy lifestyle behaviors and chronic disease management, primary and secondary prevention. You can see that some of the areas of focus of importance are really to expand awareness of modifiable risk and protective factors and effective interventions. And I think also these social support measures that increase the contribution of social and built environments to healthy living and adoption of healthy living behaviors. So as I say, I think many of these important areas of focus within the public health perspective on dementia are aligned with some of the tried and true goals of many of the public health units. Some of the core research themes, again, interestingly, primary prevention, treatment and secondary prevention, quality of life. So a lot of different programs are identifying these key things. Another thing that public health does really well is awareness campaigns. And a key focus of the national dementia strategy is also trying to reduce or eliminate stigma, promoting and enabling earlier diagnosis. As I was saying, there's a lot of evidence that dementia is actually underdiagnosed or undiagnosed. And then building the capacity of care providers as well as the support for family and friend caregivers. People talk a lot about the notion of dementia-inclusive communities. So it's not even just raising the awareness of dementia amongst caregivers or people who might be at risk for it. It's also about society taking a broader approach to creating awareness about the disease and creating a sense of how can communities do better to accommodate people with dementia and their caregivers. To that end, it's almost like the whole realm of different professionals and people involved with the care of people living with dementia includes not just health professionals and not just personal care workers, such as personal support workers or paid companions, but definitely family, friend caregivers, and also first responders. There's been some attention now to sort of what can paramedicine do as well. It should be said that another aim of the national dementia strategy is, no person left behind, identifying some of the marginalized groups, those who may be at higher risk with respect to dementia or caregiver challenges, but also those who may face barriers to access to health. So again, these are some of the populations that are also clinically difficult to serve and may also be targets for other public health interventions as well. Okay, so that's a little foray about the national dementia strategy. Let's focus on an issue that I think some of you have addressed, and that is what is the increasing risk of falls with dementia? So I'm putting that out as a polling question because particularly in the province of Ontario, there are a lot of folks who are involved with falls prevention as a focus. And I'm curious as to whether or not there's an appreciation of whether or not there's an association or an increased risk. Oh my goodness, this is a a very educated falls prevention group. So yeah, so the risk with dementia is absolutely increased. It's at least 5 times. Probably most estimates are the risk, depending on the stage of dementia, is 5 times. If you have hearing loss, your increased risk of falls is higher. So while you may not consciously have dementia or caregivers on your radar just yet as a public health priority, you may have come across it with respect to the falls prevention side of things. So speaking of caregivers, how many of you have caregivers sort of within your portfolio? Are issues affecting caregivers, are they seen as being explicitly within your portfolio? So I'm going to open that polling question to see how many of you are addressing caregiver needs explicitly within your mandates. I don't know if we're seeing that polling question just yet. All right, I'm gonna move on. This issue of caregivers, this issue with respect to caregivers is an increasingly recognized challenge. I'm gonna put that polling question on hold for now. We'll come back to that one later. But increasingly, some of the institutes in Canada, like Canadian Institute for Health Information, have recognized and begun reporting on challenges affecting caregivers, and in particular, people caring for those with dementia seem to be under more stress than other caregivers. They put in more hours, they're more likely to feel distress and have issues with anxiety and depression. Some of the other things, they're putting in many hours. Some of them also have paid work as well. The 45% are unpaid caregivers. You know, the personal cost that many people are incurring in their role as family caregivers is high, and those caregivers themselves may need additional supports. So it can be very challenging, and the evidence suggests the burden is high. Within Ontario, we have Health Quality Ontario. I think it's now called Ontario Health, or it's part of the new Ontario Super Agency. But again, and there's been this appreciation, not just the number of people with dementia living in the community going up and increasing pretty dramatically across the province, but also that nearly half of the caregivers who are looking after those with dementia are experiencing problems with distress. So this whole issue with respect to caregivers and caregiver burden being a broader public health challenge is recently hit the map, not just in Canada. In the United States, the Center for Disease Control has identified the caregiving for family and friends as a major public health issue. And actually, internationally now, the World Health Organization has identified a number of issues with respect to dementia being kind of a global public health issue, so that the Global Action Plan and the Public Health Priority, they've identified, one, dementia as a public health priority, dementia awareness, dementia friendliness, same as dementia inclusive communities, risk reduction, again, trying to address some of the healthy lifestyle and preventative strategies, improving diagnosis, support for dementia caregivers. This is absolutely on the global public health landscape, and improving information systems in addition to research. So I do want to highlight that and thank the team from Ottawa Public Health, because I want to illustrate there are a couple of ways in which both caregiver education and dementia or brain health, healthy aging are being used within the Ottawa Public Health context. Now, they've had a focus on healthy aging and brain health for several years now. I think they were a bit ahead of their time with respect to that. And they've produced resources like the Caregiver Guide, which is excellent, and brain health, all from their website. Again, a focus on brain health. And many of the things that they target related to their brain health are, in fact, healthy lifestyle behaviors, common tips. So I'm gonna open the poll now. We'll go back to the question before. So Ottawa Public Health has a strategy around caregiver wellness, caregiver health, and brain health. Are issues affecting caregivers explicitly in anybody else's portfolio? So that polling question is available now. Yeah, so it sounds like actually almost a third of you are engaging with this issue of caregiver health. Very interesting. And I guess this is another question then, you know, Ottawa Public Health is doing a great job with their web-based resources and trying to reach out to caregivers. The education has been identified as a really important part of the dementia strategy, education for many folks, but particularly increased education for informal family caregivers. So this polling question, and this is multiple select, if you are currently involved with caregivers of people living with dementia, how do you currently meet their needs? So in addition to the website, and I'm going to say that Ottawa Public Health actually is involved with a number of regional policy and planning groups. They have an excellent dementia network there, and they have sort of a seat at the table and a really good collaborative relationship. But I'm wondering how many others have this kind of strategy, and what are some of, if you are currently involved with those educational strategies and focus on caregivers, what are some of the ways that you try to tackle this? Face-to-face education, is that something that you do, or is that more related to another agency, like an Alzheimer's Society or a Dementia Society? Are you involved in any kind of remote education, like webinars or video conferencing? Some people might curate other web-based resources, and then there's other folks that might develop their own resources or direct people to community agencies. So kind of interested. So directing people to community agencies, face-to-face education is that's great. So those seem to be the two most common approaches. All right. Well, one of the challenges that we tried to address was what do we do in a busy clinical situation? And this is where my friend and colleague Richard was in the position of where do you start? And if you want to say a little bit about what happens on the ground in your clinical situations that sort of prompted all of this.
Sure. Thanks so much, Anthony. You've done a great job of setting up how prevalent a condition dementia is and how many people suffer with the condition, as well as all the caregivers and the economic impact and the human impact that the illness has on people. And we see it all day, every day in our clinics. And it's a very complex illness as well that takes a very detailed history to get to the bottom of. It impacts people's behavior and personality. It impacts their ability to function day to day. So they may not be able to pay their bills, or they may not be able to drive a car anymore. And so we have to address all of those functional issues. There are medical conditions as well, such as thyroid dysfunction or kidney dysfunction that can also contribute. So we have to do a full medical review as well as a complete medical review of systems and review medications, perform bedside cognitive testing, where people may have to do pen and paper tests so we can see how their brain is actually functioning across different domains, testing things such as their memory or their problem-solving capacity or their ability to do visuospatial processing. So by the time we get through all of the information, I neglected to mention reviewing brain scans or reviewing lab information, it may take about an hour and 15 minutes. And so, as you can imagine, the people in the clinic are quite tired and exhausted by that point. Then it comes the point where you disclose a diagnosis to them that is life-altering, and so they can be a little bit distracted at that time. If I launch in at that point in time to describing all of the things that they should do for brain health activity and all of the ways they should be managing their symptoms or medications I may be changing or altering, it's very overwhelming. At least it appears to be to us in the clinic. And nobody, almost nobody, brings a notebook with them. So the actual capacity to transfer knowledge in a meaningful way that's going to impact them when they leave our office, I think, is negligible.
And I guess you and colleagues also did a little bit more of a systematic study, too, of what caregivers in your clinics were looking for.
Yeah, so Tom Ringer at the time was a very keen medical student who did a qualitative study, which we helped out on, but he did a needs assessment of caregivers in our clinic, and he found that people weren't accessing a lot of care that was provided. They did note that they were exposed to a lot of online resources, but they didn't know which specific resources to trust, and oftentimes they felt overwhelmed by the sheer volume of information. They were presented all facets of dementia all at once, and as you all are aware, not all information pertains to all stages of the illness, and people experience it very differently. It's a heterogeneous disease. Dementia is an umbrella term for many different subtypes, and they all have their nuances. So people were actually requesting something that was focused. So, you know, my healthcare provider that I'm seeing signs off on this information, and it's very practical-oriented and goal-oriented and reflects what I am actually dealing with or what my loved one or family member or friend who's suffering with dementia is experiencing.
All right.
At the time.
So this is really what prompted you with blind ambition to basically create iGeriCare.
Well, yeah, I mean, create it alongside yourself. And so we really wanted to have focused lessons. So all of the questions that are coming up most frequently in our clinic and the education lessons or focused lessons that we would provide in our clinic can now be represented across 10 different focused lessons on the iGeriCare website, which are all put into play by Dr. Levinson and his very talented team with respect to best practices in online e-learning. The graphic design is top-notch. There's a lot of attention to those issues. All of the lessons start off with some sort of clinical vignette to set the stage and talk about a narrative that is commonly experienced by people that have dementia, and then it allows you to focus the story around the topic that you're trying to discuss with some sort of resolution to that story at the end of the lesson based on the information that you've learned throughout the lesson.
With your virtual coach, Dr. Stramko?
Yes, yep. And so we clearly set out objectives for each one of the lessons, and we'll come back to those lessons, these objectives at the end of the lessons, and there are also questions that can be asked and answered as the lesson progresses.
Yeah, we also get folks to rate each of the lessons at the end, and we'll tell you a little bit of summary, I guess, of some of that. But spoiler alert, people love them. Yep.
Just to say a little bit about the development of the lessons too. So, you know, we had an idea of what we thought were the most important topics, And then we took it to the nurses and allied healthcare professionals that work as case managers in our clinic, who are often doing a lot of the frontline education as well. Then we went through additional, I would say, super users who are people that have gone through the whole process of being a caregiver, of people that have dementia, and everybody would read and edit and review the lessons so that we distilled it down to the best quality information we could.
It was really, I'm going to say, like a great model of participatory co-design and co-development from that standpoint. In addition, like the iGeriCare educational platform, while the 10 multimedia lessons on the array of various topics that we just looked at, we also do a live web-streamed kind of monthly live event, and those recordings on various topics are available through the iGeriCare.ca website. And we've also got other formats we've been working on, podcast format for caregivers, as well as ebook format. One of our more successful ones has been a complimentary short email of the week that kind of picks up on a key topic related to the lessons. But it's, again, a lot of caregivers are on overwhelm, and so it's a nice short, just once a week email that you can read in 2 minutes. And if you have the time, it might kind of cue you to go back and look at one of the lessons. I think Richard's point about the instructional design, or how the technical and instructional ways in which the lessons are put together is a good one, because there is a lot of web-based information out there, but it is not necessarily designed for how people learn. It may just be textual information, and I've just put up, there's a whole science of, I'm going to say art and science, of evidence-informed online learning. And there are a number of principles that have been shown through a series of randomized control trials and even kind of meta-analyses and systematic reviews. These principles have been shown to impact pretty dramatically how effectively people can learn and transfer that learning. So, again, one has to take into considerations the budget, time, who are you designing for. So there's no like cookie cutter approach to this, but to the best of our knowledge, our team always tries to incorporate some of these key principles in how we design the e-learning. So for example, multimedia. People learn better with well-designed instructional graphics in addition to text. The modality principle. People learn better with an audio narration than just reading alone. But the redundancy principle, don't do both. Don't do both at the same time. Don't have the text on the screen in its entirety and force people to read it and listen to it at the same time. The personalization principle, where the voice of the narrator is a little bit informal but still polite. There's a coach. There's embodiment of the coach. That's why we have the avatar of Dr. Stramko. We leverage examples. So all of these e-learning design principles that I would enjoy going on and boring you with for a long time, because I love talking about e-learning instructional design research. But suffice to say, I think that's the other reason why we felt it was worth investing in the development of iGeriCare, is we were not seeing a comparable sort of web-based education for caregivers of people living with dementia that we thought, ticked off all the boxes. So there might be online content and information, but not necessarily high-quality e-learning that's been educationally designed. So we've been around now for, I guess we launched in over a year ago, about July 2018. And we've been really successful in terms of our outreach, and we really appreciate the feedback we've gotten from caregivers along the way. We've had over 90,000 visitors to the site. over 100,000 sessions. The videos of our live events have been watched over 1,600 times. And we use that simple Net Promoter Scale, and we have very, very high user satisfaction ratings for the lessons, for the live events, for the site as a whole. So we've been really grateful for the positive feedback that we've had, and it's really, really encouraging. I'm going to say that part of that is also due to the collaborations that we've had, great partnerships with our local Alzheimer's Society, with other groups like Ottawa Public Health, and like people are finding this very helpful and useful.
I think one thing to point out too that's key is that people are making it to the end of the lessons when we're reviewing, are you getting through 50%? The majority of people are actually viewing the lessons to completion as well as the live events to completion. And I think these numbers really speak to the scalability of the solution. And something that I know we were talking about at the beginning was, how do you duplicate the capacity to educate? And if there are this many people that have dementia in Canada, how are we going to meet that educational need? It's not just going to be face-to-face, and how do we scale the high-quality educational information that we have amongst clinicians?
And actually this dovetails really well into some of the qualitative research that we've done, where we were trying to find out, as part of the implementation of iGeriCare, well, what do key stakeholders now, like clinicians, physicians, those working with caregivers, what are they doing now? What do they think of iGeriCare? What do they see as some of the barriers and facilitators? And we did a pretty extensive theming and looked at frameworks for coding that. And I think that people have found this to be a very flexible and accessible means to complement their other training modalities. So this is not by any means a replacement for face-to-face caregiver sessions, but this is something that can complement those for those who may not be able, for geographic reasons or reasons that they can't get respite, or reasons of what's available in their area. They may not be able to attend caregiver face-to-face sessions, or at a certain point in time that commitment may seem daunting, and they need a little bit of education in the meantime to kind of sort of put the wheels in motion and maybe make them to commit to another form of education. Certainly for many family physicians, they would not necessarily have the time to do this kind of education in office. So I think as a resource that other clinicians can use, it's been helpful. And the qualitative research, I think, also revealed a few other things, that people were looking for tools to help with implementation, and we had some really good feedback on that. So we developed to the right side of the screen is just a poster that people have been putting up, either in hospital settings or long-term care or in clinic settings. And then we also have some clinicians using educational prescription pads, and these are basically just like a prescription that a doctor might write out, but when they can select and tailor which lessons might be appropriate for the caregiver at the time that they're seeing them. Rich, I know you sometimes will ask to take the caregiver's phone and scan the QR code and sort of bookmark the website for caregivers, just so it's sort of top of mind. These kinds of simple implementation tools, I think, are also helpful to allow the clinicians to offer something to caregivers.
I just think, too, informally, so we'll need to do further assessments in our clinics amongst the case managers, but the case managers have really taken to this and have started to use it even before people are getting to clinic now, if they're on the wait list. And it's just used ubiquitously through our clinic, and everybody finds it improves the efficiency with their workflow, but also their ability to engage caregivers in an educational process that's a bit more structured.
Yeah, I think this is a good tool even depending on the availability of caregiver groups, and certainly many of the Alzheimer's Society, First Link, or Dementia, they have a lot of groups in their regions, but even to be able to offer something to somebody on a wait list, maybe they're waiting to get in to see a specialist, or they're waiting for the next caregiver group to start up. I think we're also just in the beta stage of testing a web-based version of these educational prescriptions. So again, giving somebody a tool that they can send tailored links of lessons to a caregiver. So yeah, those are. I think we've got a lot of other research that we're interested in doing. We have some goals to continue to collaborate to develop a French language version of iGeriCare, to continue to improve the breadth of topics, even if we think, hey, we've got the core 10 lessons, but there's other target audiences, other research that we hope to do with the platform. So I'm gonna just pause there for a second and just see if there's any specific questions about iGeriCare, and I wanted to cover off a few other things with Rich before we go to the full discussion time. But if there are any questions about what we've covered so far, feel free. The one question that came in was asking for copies of the slides, and I will send a cleaned up version of the slide deck because I sent an unclean version with 420 hidden slides. So when we get a chance to prune it out, we'll send a copy of the slides to the NCCMT to circulate.
That's great. And just as a reminder for everybody, if you have questions, please send them to the chat box and send it to all attendees, and then we'll all be able to see your questions.
All right. Well, why don't I'll keep going, because I think I want to have lots of time for questions, but I just wanted to talk a little bit about, because it's kind of an interesting domain. It's almost a new-ish domain, this domain of web-based caregiver education. And I always like to go to my handy-dandy health evidence to do searches for systematic reviews. And this is a kind of topic that is one of the articles, because I think I had checked a few months ago if there was any new systematic reviews on health evidence, and the increase in publications around web-based caregiver education, there's like a 13% per year increase in publications over the last few years. So web-based caregiver interventions are quite popular, so much so that there's actually been quite a few different systematic reviews. And I just wanted to talk about a few of those. One of the most recent ones was Deacon et al. From 2019. And again, this was an evaluation of technology-based interventions for informal caregivers of patients. And the consistent messaging is that the combined interventions show pretty strong effects. There's almost always significant post-intervention effects of the technology-based, especially for things like caregiver stress, burden, or depression. Another recent systematic review and meta-analysis of RCTs by Williams in 2019 also showed small but significant effects, and again, particularly for what they call multi-component interventions. Spencer was another one, another 2019 review, also showing that one or more measures relating to carer mental health improved following technology-based interventions. There were a couple of excellent reviews from our School of Nursing here at McMaster, Diana Sharafali in 2018, Jenny Plegg and colleagues, Maureen Markle-Reed and others. And their systematic review was more broadly on caregiver mental health of internet-based interventions beyond just dementia, but definitely found benefits of internet-based interventions for caregivers of adults living with chronic conditions. So it could have, and the outcomes they were looking at in one paper, improvements in depression, stress, distress, and anxiety. And, again, I think what's interesting about these meta-analyses and systematic reviews is just appreciating some of the complexity around even nailing down what are we talking about, because some of the interventions themselves, like when we talk about technology-mediated interventions, some of these are actually, telehealth, telepsychiatry. They might be actually, therapeutic groups using web-based tools. Others may involve skills training. Still others could be like an online discussion forum. So it's quite heterogeneous, and this is what we find when we look at e-learning. It's like, well, what are we talking about? Is it video conferencing? Is it email-based stuff? So, and then again, some of them are the interventions might be targeted to the caregiver and the person living with dementia, the dyad or adult versus like adult children who are caregivers versus spousal caregivers. What is the level of comfort with technology? So older studies from, a decade ago, now technology is much more acceptable and high rates of adoption are occurring amongst older adults. Our demographics of people using iGeriCare suggest that most users are, over 55, over 65. The demographic is consistent with the caregiver demographic. Multi-component interventions, we try to capture different elements within even the education. So, and this is consistent with what some of the findings were from the meta-analysis systematic reviews, that, there are knowledge and skills, and some of that involves really important pieces around what we call cognitive reappraisal, where, somebody may be interpreting the person with dementia's apathy as, well, they just don't care, and they get frustrated, whereas if you can provide education about a symptom like apathy, it may help the caregiver with that cognitive reappraisal to be more understanding, to be less hard on themselves, feeling like they're not doing enough to engage the person with dementia. And then coping skills, but as I say, some of the studies, when they're talking about web-based interventions, they might be more leaning towards psychotherapeutic interventions using mindfulness or cognitive behavioral therapy. So I did just want to highlight that quite a few, while the literature strongly supports the benefits of web-based caregiver interventions, there's a lot of different types of interventions out there, and all right. So there's a few questions in here. One of them was about whether or not there is a cost to the user, and in fact there is no cost to anyone to use iGeriCare. It's open on the public internet, iGeriCare.ca. You don't have to create an account. You don't have to pay anything. The live events are also open. So it is a freely available resource, and we should, I think in the acknowledgements we'll be talking about the folks who have helped to support it. It's been supported largely by the Center for Aging and Brain Health Innovation, which is powered by Baycrest or CABI through grants that we've been able. But we've been fortunate to have Hamilton Health Sciences Foundation, Geris Center, our local Alzheimer's Foundation. So there's been a lot of people with support and in-kind contributions. Can I find out who among my professional colleagues already knows about or uses iGeriCare resources? This would help me in targeting my channeling of your resources. I don't recognize anybody from your organization that we've had one-to-one talk with, but we do have a lot of different groups that use iGeriCare because it doesn't really involve permission at all. Sometimes people will contact us and they will ask, can we, can we have an educational prescription pad? Or they'll ask for clarification, is there cost? But because there's no cost and it's open, many people are using it and incorporating it into their clinical workflows, and we won't know about it. So it is possible that there's somebody in your organization that is using it, but I think probably great to target somebody and just that's great to let people know it's there and free to be used, and yeah. So there's somebody else saying that it's the first time they've learned about it, and I think that's, well, I think many of us would find, whether in public health or in one of the challenges, and this is interesting in looking at the systematic reviews and the meta-analyses. So one, when we did our qualitative research study on implementation and barriers and facilitators of implementing web-based caregiver education, despite the range of randomized trials, there was actually nothing out there on, okay, so how do we implement it? And I think the other thing is that, many of the studies that might have been done, RCTs, they were probably developed, the interventions were developed, but they may have only been used in the context of that research study. So when we look to try to find all these resources that have been studied, these various web-based interventions, well, they're no longer in operation. So somebody did a study, but then they couldn't get funding, it wasn't sustainable, or it was just done within the confines of the trial. There's a couple of them, but they have a cost, so there might be a paywall associated with it, or they were actually like telehealth interventions, so you'd need to kind of sign in and use secure systems like Ontario Telehealth Network or things like that. So I think that's a roundabout way in terms of, like, this is the first time I've heard about it, is one of the elements around any of these web-based interventions is it's not usually just a question of if you build it, they will come. People need to find out about these things. How do they find out about it? How does it get implemented and incorporated into clinical workflows? And I'm going to say it happens in part through raising awareness about it and somebody saying, yeah, we have this need. We would like to implement it, and then approaching various folks, whether it's if it's caregiver education for dementia or dementia education's on your public health roadmap, then here's a resource that can be curated. If you have folks in more clinical settings, like letting them know about this, and we're happy to provide people with educational prescription pads or posters, or if they're keen to try out our new electronic version of the educational prescription. But it can absolutely be built into clinical workflows, and that was one of the findings from our qualitative research. Is folks were like, oh, this is really easy. I don't need to tell people, oh, they need to set up an account or whatever. I can just direct them to iGeriCare.ca. I guess I'll put a question out to you guys with respect to caregiver or even just web-based education. What are some of the strategies that you guys find helpful? Like, what are some of the barriers or facilitators that you found around incorporating web-based educational resources? It could be about falls prevention. It doesn't have to be about dementia or dementia caregivers, but I'm interested to hear, what are some of the implementation tips? Because I think this is an underappreciated challenge around it, and obviously I've been involved in the design and development of e-learning for a while, that there's often people who have great ideas, develop good resources, but driving people to use it. So, yeah, Nancy had a good suggestion, sending links via email, brochures. So, yeah, I think it is one of these things that's it's a multimodal strategy. We talked about multi-component or multimodal. You know, providing a brochure or a handout or a takeaway that might also have the link to it. If you have a mailing list, sending it up. Linda's got a suggestion. In home care, frequently refer to First Link or to Seniors Mental Health for caregiver support, as well as cognitive testing. So, you know, I think that's probably a relatively common approach. I think the regional geriatric programs too are also, you know, it's a lot of folks that, you know, how do people hear about these resources is probably multimodal. Social media, Facebook, Twitter. I think some of that. I think that's some of how we were able to drive traffic to iGeriCare is we did have some digital media marketing resources. I think that there's only so much traffic and success you can get from what we would call organic social media, unless you have a huge following. It's pretty hard to, you know, continue to get and build new awareness. Local support groups are limited as in a rural area. So, you know, I think there's absolutely a possible role for something like iGeriCare in environments that are more rural. Of course, that is also a domain where sometimes people's access to internet is more limited. You know, we do the best we can to create e-learning modules that are optimized for, you know, low bandwidth, but still in some rural areas you may have the double challenges there.
I was actually surprised. So I used to live in British Columbia, and I did outreach in northern BC in Prince George. And so I'd fly back and forth between Vancouver and Prince George, and people would drive for 4 hours into Prince George, which is a remote community on its own. So, you know, 4 hours plus or 5 hours plus an already remote community. And we were able to do some telehealth with them in their own home, but also I think to the point is they didn't have any of the face-to-face organizations available to them. So I think this would have been a very helpful resource, unavailable at that time, but also it was interesting that despite the fact that they were remote and an older adult, they were still technologically savvy enough to engage in telemedicine visits. So.
And I find that you cannot generalize about rural communities because there are some that have much better infrastructure. Right. And you know, I remember even, you know, 20 years ago going to do a medical elective in Fort Frances, and there were already, like Sioux Lookout, Fort Frances, there were places that were hubs that were actually quite well developed in terms of their remote infrastructure at that time. So, but it can be a challenge.
One thing I'd put a question out to the group or put a question to the group is the heterogeneity of the caregivers that they work with. Because something that we've been trying to address is, you know, you could have an older spousal caregiver in their 80s, or you could have a younger neighbor or son or daughter that's in their 50s. And some people are very highly health literate, and some people have low health literacy. So trying to find solutions to address the needs of all of those individuals.
Some great other suggestions here. Implementation tips, Michael saying, you know, develop or provide a bit of a communication sales piece or a pitch for use with professionals and non-professionals. And actually, you know, if you're interested, we can connect you. We have some marketing materials and can maybe help with a bit of the elevator pitch. We've been meeting with groups to kind of raise awareness, and it is different. As you say, Rich, the group of caregivers is heterogeneous, but also so are the organizations. And I think what's interesting too is we're getting a lot of interest from long-term care, because even though the caregiver may no longer be living at home with the person with dementia, the ongoing needs to better understand the illness, and so I think the caregiver education needs continue even if somebody is in long-term care. Here's another really good suggestion from Susan. Consider targeted outreach to Alzheimer's Society organizations across the province, as well as the provincial, regional geriatric programs. Yeah, that's, and we do find that some of the Alzheimer's societies approach us. We've been collaborating with our local ones, but I think there other ones just come across our materials. And
yeah, and we've had great discussions with the RGPO, so the parent organization of all the sub-RGPs, and they've been quite helpful as well.
And certainly our colleagues in the Ottawa Public Health Unit, they have that dementia network, the Champlain Dementia Network, I think is a real model for like the networked collaborations that they've developed there between provider organizations and advocacy organizations and healthcare, like hospitals, and it really is a fantastic model of collaboration. I mean, the theory behind the new Ontario health teams, I guess, might actually bring more collaborations like that to the table. Across the country, I feel like there are some provinces that probably have reasonably well developed networks as well. I don't know what your experience was in British Columbia, but you know, I think it does vary. Some provinces, I think, have fewer resources in that sense. The potential thirsty audience is enormous. I meet people every day desperate for help regarding caregiver needs. Yeah, I think I think that's true, Michael. I feel like there are the thirsty caregiver will probably go on the internet and search, and you know, over time we hope to continue to improve our you know, organic search traffic as well. But the more the intervention agents, the more clinicians, organizations, professionals can kind of build that stuff in, I think the better, because that's caregivers have their point of contact with public health units, with the Alzheimer's Society, with family physicians, and that's another target. So as Susan's saying, develop a short PowerPoint presentation webinar that can be delivered by stakeholders. So a kind of a Salesforce train the trainer model. That's an excellent idea, actually. We have a few kind of one-pagers, but maybe a couple of slides as well. I think you're hired, Susan. You're hired. You're, tip number: emphasize and overemphasize the importance of caring for the caregivers. My psychiatrist, you can be Mother Teresa, but if you don't look after yourself, you'll be no good to anyone. I think that's, yeah, we have one of the lessons, actually, interestingly, the least access lesson on caregiver wellness, and maybe we need to move it up to the top. Yeah. It's at the bottom of our list, but I think we both agree with you. The overwhelmed, burnt-out caregiver is, you know, cannot be providing the care to the recipient either. Yvonne's got a great suggestion. Family doctors can pass on the iGeriCare postcard or pamphlet to patients and families, and I think, you know, we've done some presentations for family physicians too, and I think they are eager too. I think family physicians do see themselves as, you know, responsible for the health of their patients, which includes more and more caregivers, and so I think a resource like this is something that family physicians, nurse practitioners, those in primary care, I think it empowers them to feel like they can provide a resource for their patients. That's great. Any other questions at all before we could move into the big finish? But I really like people's suggestions. I guess the bottom line, it's challenging sometimes without marketing dollars, and the reality is we're all cash-strapped. The social media strategy really depends on building a large organic following, or it depends on paid digital marketing, which most of us can't afford to continue to do. So I think ultimately the boots on the ground and, engaging stakeholders, finding those people, like what we find is those who come across it absolutely, endorse it. These net promoter scales. It's hard to be the net promoter scale, which many of you may not be familiar with. It's essentially a 0 to 10 scale, but you only get counted as a promoter. You only get a positive score if somebody gives you a 9 or 10 on that score. If you're a 7 or 8, you're like neutral. It's not counted, and anything less than a 7 is actually a negative against you. So it's actually hard to have a positive net promoter scale. If you were a phone company or an appliance sales company, they have the lowest net promoter scales in the country. But, our scores are very high, and the feedback we get from caregivers on the website, we have surveys, is like, hey, this is really important, this is really positive. And we ask them how they heard about us, and people are saying, my healthcare provider referred me to it. So I think it's not one approach. It is boots on the ground, a multimodal, multi-component campaign that involves engaging professionals and non-professionals, and then I think having an engaged, having some budget to go direct to consumer is great too, just because the more people hear about it. There's another suggestion. What about the concept of preparing for dementia? That's an interesting one. I think so. My wife and I know there's a risk probability one of us will experience dementia before moving on, and it's not unrelated to attending to our wheels. You're absolutely right. Like in the e-learning lessons, we also talk about planning and community resources, the importance of advanced care planning. We also had a live event where we talked about some of those issues, and I think we're probably going to hear more and more conversations about that, as people become more aware of the public health implications of it. There'll probably be more attention to primary prevention, secondary prevention, and advanced care planning in the event of. So I like that angle of sort of marketing dementia awareness, not just to continue to create more dementia-friendly communities and raising public awareness, but also to help people with planning, because I feel like as we continue to age, the rates will go higher. I think those of us, that's still one of the single most important risk factors.
I think maybe, too, using that as a motivator for things like exercise or staying socially active and staying cognitively active and doing all the preventative things you can to limit its impact if it does happen, or avoid it altogether if possible.
So there's another question from Susan. Where in the public health standards is dementia highlighted specifically? And I'm not 100% sure I understand the question, because I'm not sure I 100% understand the world of public health and standards. But what I will say, and I think I posted the link above in the chat pod to the web page from the Public Health Agency of Canada that has their Together We Aspire, the National Dementia Strategy, and you can access the content of the recently released Public Health National Dementia Strategy. The other documents that are quite useful, when I spoke about the standards, the quality standards that are put out by Health Quality Ontario, and those are quite useful and can be found on their website. I can post the link, but you could find it just by Googling HQO or Health Quality Ontario Dementia Standards. And again, in the dementia standard, they have materials around implementation guides, recommended resources, things like that. But they also highlight the importance of caregiver supports and caregiver education and strategies like that. So I think those, when I spoke about sort of the public health strategy, I was talking about the new national dementia strategy, Together We Aspire, which is available through the link at the top of the chat panel. And then when I was speaking about standards, those would be the quality standards for Health Quality Ontario. I'm not sure, but I think some of the other provinces have also elaborated something similar to the Health Quality Ontario standards, whether or not they identify specifically certain public health types of initiatives. I want to say that based on the national strategy, I think, and some of the WHO work, this concept around dementia awareness, public health awareness of dementia with the effort to reduce stigma, to make more dementia-friendly or dementia-inclusive communities, that seems to be a common thread in many of the strategies. And then around the standards, especially the HQO standards, they will refer to a range of different things, some of them geared towards the healthcare system, because they want to be able to measure, hey, how many people actually were provided with a dementia care plan in the system? How many caregivers were actually provided with a caregiver education resource? So we hope that something like iGeriCare can figure into a comprehensive, high-quality approach to dementia care, which would include dementia caregiver education as part of that. So I hope that answers the question around that. Tim has a comment. Most young onset patients have a neurologist. I think it's important to market your tool set to that group of professionals. Typically, you see a neurologist 15 minutes out every 6 months. I think neurologists are starting to think who's caring for their patients the rest of the time. Your tool set allows a discrete self-serve means to at least become more knowledgeable. Thank you very much. I think it's a really good comment. And actually, we in our qualitative research we included a neurologist who works with people with dementia, and I think you may be right. He really jumped on it. He was super enthusiastic. He was like, I'm going to tell all the neurology residents. So I think some of the constraints around some of the specialist time. I mean, Richard and I are both wildly inefficient clinicians, so we spend like an hour or two with our patients and families. The joys of really the pace in geriatrics and psychiatry is a little bit more languorous than neurology. So I like that idea.
I think we tend to view ourselves as having two patients every time we have a couple. So it's not just the person that has dementia, but it's also their caregiver, and being in tune with their needs, whether they're physical health or mental health, and providing a lot of counseling to them is definitely very important to us. So sometimes that's great.
Yeah.
Because sometimes we exist within our own bubbles and our own patterns of practice, and to really disseminate this widely, it's understanding what everybody across the spectrum of dementia education is dealing with.
Well, thanks so much. I'm gonna move into the big finish. A few concluding slides, and then I'll hand things back to our hosts. We really appreciate the implementation suggestions, and I think Richard and I, we have a few fingers in a few pots, and the neurology cadre. There's I feel like we can focus on them for a little bit. I agree with you. Certainly the younger onset patients, and that's actually an area of content that I think we would like to focus on as well. So, again, if we take revisit our scenarios, we've now got something to offer the caregiver within the clinical setting. We would imagine that the home care nurse can complement, almost in an ideal way, complement what's going on in the home, answer some questions, almost like we would call it a blended teaching strategy. And then, I think we're seeing the Alzheimer's Society picking up on the resource. Again, maybe something that somebody can do on their own time and bring questions to the group, or maybe tip somebody over to accessing the group. This, I hope, and maybe we're preaching to the converted. Maybe the folks on the call today are seeing dementia and caregiver as part of the public health agenda, raising awareness, the healthy lifestyle and preventative aspects, helping to target some of the high-risk populations or those with barriers to access, and you know, the trying to within the constraints of cost to kind of reach and help as many people as we can. We do see that generally web-based resources can complement the traditional or other education approaches, whether it's pamphlets or face-to-face. The blended approach, I think, can help with some caregivers who may have problems with access, maybe boost knowledge, awareness, and self-management skills. And then, you know, I think we see this as part of that broader public health strategy, and raising awareness about dementia, and understanding this seems to be a national priority. I think is raising it amongst our trainees, because this issue also of under-recognition, under-diagnosis, but helping to reduce the stigma and improve quality of life for caregivers, and hopefully continue to focus on, you know, treatments and cures and research and trials. They catch news headlines. There's a lot we can do around primary and secondary prevention, likely with some of those healthy lifestyles, behaviors, education, helping to delay onset, and those are things that we can do now. And I think we could all be doing more of those. Not that changing lifestyle and behaviors is not simple, but some of the resources for more, iGeriCare.ca, obviously, the Public Health Agency of Canada, health evidence for systematic reviews, and the HQO standard I mentioned. There's the proper version of that slide with correct branding. And I just want to acknowledge our team. I'm really fortunate to work with a great group of people within McMaster, and our acknowledgement of funding, particularly from the Center for Aging and Brain Health Innovation. So I am going to hand the host status back to Health Evidence, and I want to thank everybody for your questions and participation today.
Great. Thank you so much, Dr. Levinson and Dr. Stramko, for that really informative presentation. It was really interesting to hear and learn about dementia in the lens of public health as well. So we do have a slide here about any comments or questions, but I think most of them probably already got answered. Maybe if you think of any other additional comments or questions, please feel free to email it to us, and we can answer them and pass them along to Dr. Levinson and Dr. Stramko as well, if they're okay with that.
Absolutely.
Okay, great. So we just have a few more polling questions, and we really thank you all again for participating in our poll today. It really helps us with our webinar evaluation and making sure everything is going well. So the first question, participating in this webinar increased my knowledge and understanding of this tool. So strongly agree, agree, undecided, disagree, strongly disagree. The second question is, how likely are you to use the tool or method from today's webinar in your own practice? So that being iGeriCare, strongly agree, agree, undecided, disagree, or strongly disagree again. Which of the following statements apply to your experience with the webinar today? And this is a multi-choice, so you can select all that apply. The webinar was relevant to me in my public health practice. The webinar was effectively facilitated. The webinar had opportunities to participate. The webinar was easy to follow along. And the webinar met my expectations. The fourth question, can we contact you in the future to discuss how NCCMT can improve its webinar series? And then if you say yes to that, we just ask for your name and email address. So just give everyone a few minutes to answer those questions. Okay, so thank you everybody for joining us for our webinar today. If you want any more information about the National Collaborating Center for Methods and Tools, our website is up there as well as our contact information. And I just want to give, again, a big thank you to Dr. Levinson and Dr. Stramko for presenting in this webinar today and telling us a bit more about iGeriCare.